Hello everyone, welcome to sqadia.com, and in our final section of the lecture topic, Urogynaecology, we will talk about some other problems, urinary problems in the gynecology. And in this we will talk about urge and overflow incontinence, what is painful bladder syndrome, and what's overactive bladder. Urge incontinence, it can be a motor urge incontinence or sensory urge incontinence. So in this urge incontinence, there is overactive detrusor muscle, overactive detrusor muscle. In overflow incontinence, usually the uroflowmetry reveals low flow rate and significant residual urine. So in overflow incontinence, lot of urinary residual urine is present in the urinary bladder after the normal micturition though. So once the bladder is filled with the residual urine, or if the urine flow is not good enough, then bladder become filled with the urine and there is overflow incontinence, and there is reveals large capacity of the bladder on cystometry, and there is no rise of detrusor pressure during the voiding. So if you see here, if this is the bladder, urethra, and usually there is obstruction to the outflow of the urine. There is some blockage due to the stone or any other problem that leads to the failure of the emptying of the bladder completely, and the pressure in the bladder keep on rising due to increased urine. So treatment for overflow incontinence is usually surgery to remove the obstruction. If there are stones present, then usually the surgery is performed to remove the stones. Usually if there is continuous catheter drainage for non-obstructive group, if there is no obstruction, then the drainage by the Foley's catheter is performed. Following removal of catheter, residual urine has to be measured, and it should not be more than 100 ml. So after the urine is removed with the help of the catheter, the residual urine should not be more than 100 ml. Then the painful bladder syndrome, presence of, usually there is a presence of pain in the suprapubic region, which is related to the filling of the bladder. And there is usually it can be due to urinary tract infection, and then other pathologies can also lead to painful bladder syndrome. Usually patients usually presents differential diagnosis, which can be leads to bladder painful bladder syndrome, can be like trigonitis, inflammation of the trigone, tuberculosis, urogenital atrophy, cystitis, cancer, overactive bladder, bladder stones. All these can lead to or they can mimic the painful bladder syndrome. And whenever there is painful bladder syndrome, it affects the lifestyle, or it can affect the normal work of the female. Usually there is ability to work, there is sleep deprivation, there are curtailed activities because patients have pain in the suprapubic region, and it affects the normal activity of the living. So usually there is urgency and frequency of the urination and reduced quality of life. What leads to painful bladder syndrome? If you see the normal urothelium or the normal structure of the epithelial lining or urothelium lining of the urinary system, this is the normal gag layer. Usually it is lined by the glycosaminoglycan layer here. Then we have urine solutes, different bacteria, potassium, all these are present, and the glycosaminoglycan layer prevents the entry of these different structures or these different material inside the urinary system or inside the bladder. So when there is dysfunctional urothelium or when there is dysfunctional gag layer, what happens then? There is crossage of different solutes, bacteria, potassium into the urinary bladder, and all these can lead to pain, urgency, and frequency. So the problem in painful bladder syndrome is the dysfunctional urothelium. Dysfunctional urothelium cause damage to the glycosaminoglycan layer of the urinary bladder that allows the passage of different solutes, bacteria, and then potassium across the bladder wall, and it can lead to pain, urgency, and frequency. Then overactive bladder. In normal bladder, usually the detrusal muscle contract once the bladder is full and leads to the process of micturition. But in overactive bladder, usually the detrusal muscles start contracting even before the bladder is filled with the urine. So here you see in this normal, the detrusal muscles start contracting and pushing the urine out when the bladder is filled with the urine. But here it's even very little urine is present. The detrusal muscles start contracting in overactive bladder. Okay, in this slide, in this diagram, you can see this is the normal process of micturition, that once the bladder is filled with the urine, half filled, usually there is a desire to micturate, but person can control it voluntarily, it's voluntarily, so person can hold the micturition at this time until appropriate time. But once it filled to this much level, then usually there is normal desire to void. And then at the beginning of the normal micturition, there is relaxation of the pelvic muscle, and then there is a contraction of the detrusal muscle in the bladder. So with the beginning of the filling of the urine in the bladder, once it's half filled, there is urge to or there is desire to micturate, but at this point person can hold it voluntarily until it's more than half filled. And then with the process of micturiation, there is relaxation of the pelvic floor. So this was about the normal process of micturition. What happened in overactive bladder, usually there is a decreased inhibition by suprapontine brain, and then with the decreased suprapontine inhibition there is increased sensitivity to the contraction mediating neurotransmitters, and with increased sensitivity contraction of the detrusal muscle is increased, and this increased contraction leads to increased afferent activity. With the increased afferent activity, there is a decreased ability of the brain to manage this increased afferent activity, and this in turn leads to the whole process again with decreased suprapontine inhibition. So the mechanism of overactive bladder is mainly due to decreased inhibition from the suprapontine levels in the brain. Then overactive bladder, a patient with it can be due to prostate causes. Prostate is a gland present in the males. When that gland is enlarged, when there is BPH or benign prostatic hypertrophy or benign prostate enlargement, it can cause obstruction to the urine outflow, and there is benign prostatic obstruction that can lead to overactive bladder. Then we have neurological causes that can lead to overactive bladder, in which Parkinson's disease and cerebral ischemia is common. Then the bladder causes that can lead to overactive bladder syndrome can be due to some inflammation. Then it can be due to some medication, strictures, stone, any cancer, UTIs. All these can lead to overactive bladder syndrome. Then sometimes cardiac problem, endocrine problems, and detrusal overactivity all can lead to overactive bladder. The treatment is usually, if it's due to psychosomatic problems, usually it's psychotherapy. If it's due to some other medical conditions, treatment of underlying medical conditions can cause betterment of the overactive bladder. Then behavioral therapy is usually limit the fluid intake to 1 liter per day, reduce tea and coffee. Drugs like diuretics that causes increased urinary output can be stopped if possible. Then bladder retraining and is very, very helpful to control the stress, the overactive bladder. Then we have drug therapy, intravesical therapy, and surgery is included in the treatment. The bladder retraining programs is usually treat urge incontinence, and usually these actions, the bladder retraining procedures or exercises, usually they help to control the initial sensation to void, and usually when person feels the increased urge to void, controlling the urine at that time usually leads to increased control over the voiding process. So not voiding with each urge. If patient can control the voiding with each urge, usually it increases the ability of the bladder to hold the urine until it's actually full. The drugs used for treatment of overactive bladder, we have like anticholinergic and musculotropic relaxants, in which usually we have oxybutylene chloride, 5 milligram orally 3 times a day, and then it can be transdermal patch twice a week, usually used for frequency and urgency. Side effects for these are dry mouth, skin, constipation, blurring of the vision, and contraindications for these drugs are glaucoma, myasthenia gravis, and intestinal obstruction. Then other drugs used is anti-muscarinic drugs, which are tolterodine 1 to 2 milligram orally twice a day. Again, urgency, frequency, same side effects like dryness of the mouth, skin constipation, and contraindications are the same like urinary retention, intestinal obstruction, myasthenia, and glaucoma. Then again, anti-muscarinic like solifenacine, which is 5 to 10 milligram per oral daily, frequency, urgency. Then the side effects can be chest pain and flatulence. Then tricyclic antidepressant, anti-muscarinic, and antihistaminic drugs are used like imipramine, hydrochloride 50 milligram at night. They are used mainly for nocturia, urination at night. Common side effects are sedation, blurring of vision, constipation, and there is coronary contraindications are coronary artery disease and hypertension. Then the other group is synthetic antidiuretic hormone analog, which include DDA, VP, desaminodioxyarginine vasopressin, which is intranasally through the nose, 20 to 40 microgram at night. This is used for nighttime urination, and side effects are fluid retention, hyponatremia, rhinitis, and nausea, and cardiac insufficiency is the contraindication. Then intravesical therapy, medications which are inserted into the bladder, and there is installation of the medicine in the bladder. Some comes out with the urination, and usually some is retained that leads to the treatment or of the overactive bladder due to retention of the medicine inside the bladder. So that was all about the treatment of the overactive bladder and what's the painful bladder syndrome. So thank you for watching sqadia.com.